Hi folks, John Matus again. COVID-19 pre-hospital update. Uh, been out, worked a couple of shifts, saw some patients, bunch of COVIDs, most of them semi-stable BLS patients. Not a lot of high acuity, but have started to see some of that. Want to give you just again a quick reminder of the rating system. 3 thumbs up, pretty good evidence. 2 thumbs up, some evidence, reasonably reliable. Anecdotal evidence, just 1 thumb up. And when I put the little tinfoil hat lady in the slide, that just means somebody's talking nonsense. Again, trying to keep this thing kind of evidence-based and at least semi-real here. Active cases, as you can see in the U.S., or I'm sorry, worldwide, over 500,000 at this point. Split's kind of similar, right? 5% serious or critical. There's probably another 15% hospitalizations that come out of that 95 in mild condition, and then most people have relatively mild illness. Close cases on the right. Again, the death rate's disproportionately large because they don't account for a bunch of mild illness that's gone undetected. Most places, meaning most countries, are not doing an awesome job testing. Lots and lots of missed cases. And, you know, with anything that produces mild illness, that's kind of to be expected. That sort of happens because people with mild illness tend to not go to the hospital. So, hey, look at that. We love being #1 at things in the United States, and this is no exception. We've managed here to climb to the top of the list, scoring 20,000 new cases overnight. 573 deaths. It's regrettable, but again, we haven't hit the peak yet either. We're going to see substantially larger numbers. These numbers are starting to get reflective of reality. I mean, there's still a bunch of undiscovered disease still because, again, this thing was endemic long before we started testing aggressively. But the idea here is, you know, the numbers are starting to get a little bit more reflective of what the reality is out there on the street is. Italy, again, still posting big numbers. Spain climbing to #3. China's in #4. Yeah. Anyway, Germany, the numbers are nonsense in China. Like, there's just no, like, it just doesn't, you know, total cases per 1 million population, 57. It's not believable. Anyway, a couple of things to look out for. Very, very high numbers here in the new cases. And what I mean here is countries in Europe starting to put up 4 digits pretty routinely. Let's see, Canada, etc. South Korea, still managing to contain, and the data historically has been good out of South Korea, kind of an early country affected by the illness, and for the most part been pretty transparent, has, you know, good history of putting out reasonable data and not like really hiding things. Taiwan and Hong Kong also doing a great job. They're further down on the list. You can't see them here because they simply are containing, and as a result their caseload is very small. It doesn't show on this list. They're way, way down on the list. So when you look at these, they're again kind of fascinating. Today I wanted to talk to you a little bit about PPE, personal protective equipment. One of those things that becomes a little more important. I just wanted to share with you a couple of experiences of how it's affecting us here in New Jersey. I worked a shift last week. I'm on again a couple of times this week. And we're seeing lots of ER and ICU diverts. I would say 2 to 3 hospitals where we would usually deliver with are reporting ICU diverts and ER diverts. Which of course just means they're full of corona patients and they just can't take anymore, and they're basically trying to steer the volume to other locations. We have had some regulatory relief, which is kind of interesting. Not something that happens super often here, and particularly on the EMS side. Regs are pretty tight in New Jersey. Like, they don't really give us a lot of flexibility as to what to do with patients, where to go, how to staff, etc. And we've already seen relief that allows paramedics to work in the emergency department or in the hospital in general. That is usually a taboo here in New Jersey. It's truck only, it's particularly if you're a paramedic. But hospitals have used that regulatory relief to enable their medics to either work in the ER and, you know, help out and do push drugs and intubate patients, etc., wherever they can be useful. A couple of hospitals actually freed up a few ICU nurses by putting paramedics on the code team, and, you know, naturally that's where medics shine, right, is resuscitation. So why not? Retired and student nurses have been called up. That's fascinating. They basically put out a call to action for, I want to say, healthcare providers. I'm paraphrasing here a little bit. Healthcare providers, retired with or without a license, no more than 5 years ago, and I want to say like last year, student RNs. There's some details there that escape me, but it was an actual bulletin put out by the state government, basically saying, "Hey, if you want to pitch in, this is your opportunity. We could use you." The other thing is a lot of the clinicians who worked in non-acute areas, they're not needed there anymore, right? If you're an endoscopy nurse, chances say you're not going to be doing a lot of endoscopies, or if you work in, I don't know, diagnostic imaging, doing mammograms, you're just not a lot of that going on right now. So hospitals are repurposing those clinicians into other areas, which is like hilarious when you think about the idea of a nurse with no background in the intensive care unit going to work there. If you want to work the ICU, a typical pathway for somebody who's never worked there would be like a 90-day apprenticeship, right? Like a preceptorship, where you're going to work with another nurse and just kind of help out and absorb the atmosphere. And then they kind of, after your preceptorship is over, they give you your own wings and you fly solo. But now they're doing that with like 8 hours of training, maybe, depending on the hospital. Probably half of that is their charting system. So the joke here is, when you work in the primary care clinic and you get sent to the ICU, kind of miserable. So a couple of little things, again, here about the New Jersey area. BLS service is taking a lot of the hit. So again, I work a paramedic unit that does exclusively ALS cases. We classically would interface with the BLS. We are in an ambulance, so we do and can transport, but classically we're interfacing with BLS units. And I got to say, the BLS guys doing a pretty reasonable job, at least in my casual experience, of sorting out the nonsense and taking over only the patients who are critical. I mean, and what I mean here is they would release us or cancel us, but I didn't find myself assessing lots of nonsense. Generally speaking, the BLS folks doing a great job. Mobile health, we stopped doing it for most patients, particularly the things that are not super acute. Med recs, not doing a lot of that. Well-being checks, not doing a lot of that. We are doing some CHF clinic patients, only because they really desperately want to keep those folks out of the hospital. I probably would not want to go to the hospital right now if I had congestive heart failure. So we will visit patients with serious comorbidities, but we're not going out there just doing like, hey, how you doing checks. And because there's not a lot of elective surgeries, we're not seeing a lot of patients status post-procedure, right? We're not visiting TAVRs because nobody's doing that. Vents are tight. When I say tight, I mean like there are none. The facilities near B they're pretty much all out of vents. I'm sure a couple of them have vents, but the 3 or 4 hospitals that I'm thinking of right now have basically said, yeah, we're pretty much done. I don't know that they've tapped the transport vents. I know my department still has a handful of little like ATV, automated transport ventilators. Frankly, they're not really meant for inpatient use, but I'm sure in a pinch, better than not getting a vent, right? Like, can't really do like a lot of fancy stuff like PEEP and inspiratory time and expiratory time, but probably keep you alive for a little while until the vent frees up or until something else becomes available. Haven't really tapped those, so kind of guessing that may happen eventually. So again, the conversation is about PPE, so I wanted to just run a couple of quick comparisons. These are the boys over in Wuhan, the epicenter of this thing in China when it all started. So, right, goggles, face mask, gloves, obviously, Tyvek suit, right? Tyvek, yeah. Wanted to show you the folks over in Italy. Paramedics in Italy running out there. Same thing, right? Goggles, goggles, face mask, gloves, Tyvek. Seems to be somewhat of a standard, interestingly enough. Now, fast forward to the first couple of cases in America, and to be fair, these are the first couple of cases in America. Yeah, so gloves, N95 mask, right? Eye protection, but hospital gown as opposed to Tyvek. So, question becomes, why no Tyvek, right? Well, this is classically, again, what we would use in a facility for droplet precautions in the U.S. That's pretty typical. So one wonders, what is the advantage of Tyvek over this thing, and do we really need it? And the answer to that is, I'm not sure. I think we kind of need it, but I think this is one of those scenarios where we've probably not done an awesome job preparing for this thing, and as a result, now we're stuck with what's available. So let's talk about the advantages of Tyvek over a hospital gown, right? Tyvek basically shelters you, encapsulates you, right? Your whole body, including your back, feet, etc., in like a sheddable layer. So remember, again, this thing is spread through respiratory droplets. And this is, pretty okay droplet precaution under the circumstances that you're facing the patient the whole time and there's, a reasonable exchange. So hopefully the patient is contained with a mask or something along those lines. Now, let's think about this scenario, right? An EMS provider is going into a home. Presumably that patient has been breathing there, right, for several days, coughing, sneezing, etc. And respiratory moisture settles, right? It's kind of all over the place. So this provider, as she brushes up against the couch with her leg and maybe kneels or backs up against a wall or something along those lines, is likely to have respiratory moisture deposited on her uniform. Is that incredibly dangerous? Well, I mean, the science says this thing can live on surfaces for several days, some more than others, but the idea and the reason why other countries have been wearing Tyvek is because they don't want to track that stuff. So the question is, why no Tyvek? And the answer is, I don't think anybody has it in quantities that are significant. So if the CDC kind of went out there and said, hey, you guys should all be wearing Tyvek on these jobs, I think most clinicians would lose it, right? I mean, we're already seeing people freak out pretty good about the lack of N95 masks. So honestly, I kind of get the feeling this is a resource issue and not a best practices issue. I also want to point out this fella. I don't even think he's wearing gloves. I mean, maybe that's a glove, but that's certainly not a glove 10. I don't know what's going on there. I don't actually think this guy's part of the EMS team. I think he's part of the nursing home. This is the nursing home in Washington State where a number of people died. Again, this is one of our first cases, so it's reasonable to think we're going to have to learn some lessons before we figure it out. Not that we didn't have a chance to learn from the Chinese and the Italians several weeks before, but, we're Americans. It's what we do, right? We sometimes need to be taught a lesson the hard way. But, this guy's really worried about protecting the privacy of the patient. Noble effort, but there's like 7 photographs of the patient's face when they get loaded into the truck. I mean, this is not the only shot from that particular event. And the idea here is this guy, took the time to put on a surgical mask. You can kind of see the loops here, but not necessarily like protecting anything else. And is that reasonable? Well, it's probably not in contact with the patient, but still the inconsistencies in the practice. And it's one of the things that we do all the time in the US. Like, these folks are regulated by the EMS board. They do one thing because they get one set of recommendations. These guys are likely regulated by the Department of Health more generally, or perhaps the Board of Nursing, or whoever, and they have a completely different set of instructions. So the different licensing boards in the US sometimes create some dichotomies in how we do things. But fascinating to see, like, this was our first foray into this, and I'm not really sure we got off on the right step here. So I wanted to point out an example of that. I pulled this, references on the bottom there, but I pulled this off the internet. It was kind of I don't want to say a puff piece. It was like a feel-good community article about how the local fire department in Virginia is like, yay, ready to go for this. And they talk about all the PPE that they have. And they have 130 Tyvek suits. And they're not using them because they're waiting for the CDC or the Virginia Department of Health to say, use them. And this is where I'm concerned, because they're waiting for some holy authority to give them the blessing to do this. And I gotta say, the CDC has not been super great at getting out there proactively and giving good advice. I mean, I kind of feel like they're trying, but I also kind of feel like they're hamstrung by the lack of preparation, and thus they can't be as transparent as they'd like to be. Because I think if we had the right amount of PPE in stock, and I don't mean like every agency, I mean just on a national level, I think if we had the capacity to have PPE in the volumes, quality, and quantity type that we wanted to, I suspect our recommendations would be a lot different. I think we'd see a lot different type of guidance from the federal government on this thing. So sometimes you give the guidance that you can based on the equipment that you have available, and again, I don't know that that's best practice. So the mask dilemma, this is something I wanted to talk to a little bit, because maybe you went to EMT and medic school and you got a really good explanation of these devices and what they're supposed to do for you, or maybe you went to nursing school and you kind of learned all about these things and you are super great at selecting them, or maybe you've just kept your ear to the ground in the last 3 weeks and there's been so much talk about these things that you now know the difference. But in case you're not 100% familiar with what these things do, this is a surgical mask and it does nothing but capture exhalation. That is its job. It is not a respiratory filter. It doesn't clean the air or scrub it for you. It simply catches stuff on the way out of your mouth. That's what it does. This thing is a respiratory filter, right? This is something that fits tightly around your face and it is supposed to capture the viruses here on the outside. I'll put little particles there. So that when you breathe the air, it's reasonably clean and does not have virus in it. So this is a piece of PPE, and this is mostly something that keeps you from aerosolizing mess to the outside. Now, we in EMS absolutely love to give people crap for wearing these. And when I mean people, I mean like the general public, right? We love to see a layperson walking around with a mask, and we love to give them a hard time. And there's a reason for that. First of all, we don't feel like they need them. But again, here's the CDC discouraging masks by the public. Hey, if you're not sick, don't wear these things. They're in short supply. Same for the caregivers. World Health Organization tells you the same thing. Hey, we don't really recommend you wear these things unless you're sick or unless you're caring for someone who is sick. Why? You know, not enough. There's just not enough of these things. And I get it. This is resource maximization, right? This is us doing a lot with a little. This is us making those masks stretch because we can't give one to everyone. And when we see people wear them, we like to give people a hard time. Now, this may be a little excessive. She's wearing an N95. And listen, whatever, she wants a respiratory filter. People are scared. She's wearing the gloves, right? She's like super well protected. Now, you know, I don't know if this lady knows how to wear this thing. There's a tiny bit of skill to it. Like her nose piece might not be molded right, so she's getting air in here. She might not have the rubber bands in the right place, so the thing is not like tight enough on her face. So there are lots of potential causes or potential variables that make this device totally useless on this lady. And I totally get where people sometimes get a little like snippy at this. Because maybe that could be on, you know, some intensive care nurse's face doing a better job. I understand. We also, though, sometimes love to give people like this a hard time. Because this is not a respiratory filter, right? So for this woman to wear this and go out shopping when she's not really getting a lot of protection from it seems to be kind of useless. But I wanted to point out something. This is a disease that spreads out with asymptomatic transmission, right? This is an illness that gets around and transmits from people who do not know they have it to other people. And this is why the spread is so high and the R naught is so high. So what I'd like to point out here is this lady is spreading far less germs than anybody else. She is disseminating less virus than other people who are breathing more freely into the atmosphere. So she may not be protecting herself a whole lot by wearing that thing, but she is at the very least not spreading it. And that's part of the solution here. So maybe we shouldn't be giving this lady a super hard time about it. Now, again, we could argue that that mask may be necessary elsewhere, but this is, again, where I think the opportunity is lost, because we can do a little bit better than this. And what's interesting is, the situation is so desperate, you may have heard this last week, that the CDC pretty much said, hey, got a scarf or a bandana? Meh, might as well use that, because better than having nothing. And again, I'm going to be fair to the CDC. It is a last resort. They didn't say, like, you know, throw out your N95 and wear a scarf. Like, that wasn't their point. But what they are saying is, hey, if you have to home make a mask, that's probably better than wearing no mask. So give that serious contemplation when you're out. And that's probably a fair statement. But basically, they're at the point where they're saying you might have to kind of go lean on these things. So this is, again, where I think the opportunity is lost, because the government here is looking at a situation that's pretty desperate. They're handing out guidelines that are like near ridiculous. I mean, so ridiculous that even I have to meme them a little, you know? I, when the government basically said to wear scarves or bandanas, I started putting NIOSH stickers on the most ridiculous masks I could find. Because, geez, man, if you can't laugh a little, right? Like, crazy. So, NIOSH is the organization that accredits respirators. And the joke is that, this guy's half an orange is probably NIOSH approved at this point because the government's so desperate for any form of PPE. The point, however, is that there's kind of a better solution, and I think we can sort of look to history a little bit. Because the civilizations that are doing well with this are civilizations where wearing a mask in public is no big deal. They do it all the time. You go to Hong Kong or Taiwan or South Korea, these are, by the way, some of the countries that are dealing the best with COVID-19. Like, they have some of the best figures going. They are containing this the most and blunting the impact and flattening the curve better than anybody out there. And these are all civilizations. They're cultures that went through several scares too, right? They dealt with MERS and they dealt with SARS, and some of these places deal with pollution, particularly China, on a pretty regular basis, like serious amounts of pollution. So people pretty routinely walk around like this. And again, when 90% of your community is wearing a mask, they are shedding far less virus than the people who aren't wearing a mask, right? That's intuitive, and when we have better research on this, I think you're going to see that it's also going to be evidence-based. So the question is, how do we equip everybody with masks like this? Because we don't have the supply chain, right? We don't make things in America, so we certainly don't have mask factories to do this, and the countries that make them aren't really selling them right now. So how do we manage this? Well, again, we can look to history a little bit, because now even the CDC is starting to think about recommending that the public wear face masks. This was today's Washington Post. So the CDC went from, oh, you don't need one of those are just for healthcare workers or if you have somebody sick at home, to, hey, wear a scarf, just as good as a mask if you got nothing, sort of, to now, hey, maybe we should all be wearing masks because, seems to be working elsewhere. Why don't we go with that? But again, we don't have the capacity. But I will tell you this. This is me last week. I walked into the hospital, and one of their employees had a little table, and they had an insert, like a little piece of paper that they gave us. And once we took the insert, we could pick a mask donated by the community. There were several. There were numerous patterns. I liked this one. Purple, pink, whatever. It's all good. But, I kind of look at this thing and I said, this is how we're going to end up. Once we're out, we're all going to be wearing something made by somebody's nana. And you know what? I'm okay with that. I am absolutely okay with that. It's not my first choice, naturally. I'd rather have an N95. But the point is, that is a way to mobilize your community into doing something productive. Because right now, there's a bunch of people sheltering in place. And listen, they're going to run out of decent things to watch on Netflix eventually, right? That's not going to last forever. But these folks probably, they're being asked to stay at home, and they probably would like a way to contribute. And what's a better way to contribute than making some face masks? And these ladies, or guys, I don't know, they weren't signed, but they took it upon themselves to make some masks and donate them to the hospital. And I kind of like mine. I think it's pretty great. Definitely going to wear it when I run out of N95s, with a degree of pride, may I say. But again, we can look back, because this has happened in the past before, right? Countries have mobilized their communities, their populations, to fight off challenges in the past. This is a picture from the 1940s in England. If you don't know this particular aspect of history, they were fighting the Nazis at the time. And Winston Churchill basically told the civilians that they needed to donate their pots and pans to the government. And what they were going to do was build Spitfires. If you don't know what a Spitfire is, that's the plane on the right. They're fighters that they used to fight the Nazis. And the truth is, like, you can't make a fighter plane out of just pots and pans, but they got an overwhelming amount of pots and pans. The British public really like stepped up on this, like enthusiastically so. They wanted to like do their part, and I suspect the American public would like to do that also. So how do we motivate them? How do we get them to do this? Well, we basically tell them to make masks. And it's not hard. It doesn't require lots of special material. I mean, you can make masks out of t-shirts if you had to, right? If things get desperate enough. But the point is, um, I think they would do it. And let's do the math a little. New York Times says there's 253 million Americans told to stay home. It's like what, most of the population? Like minus 100 million or so? Let's say, you know, there's a bunch of kids in there, bunch of folks who maybe don't have the eyesight, some people without the manual dexterity, some people without the talent, although it doesn't take much. Let's say you got 100 million people who could probably do this. You got them to make 4 masks each. Now everybody's got a mask and we have some to spare. It's totally doable. And by the way, it's starting already. I told you the story of the ladies who donated them to the hospital. But there's also a bunch of like internet articles about this. People who are, you know, sewing their way to victory and donating masks for healthcare workers. And that's not just brilliant, it's incredibly, I don't know, encouraging and inspirational and absolutely vital to the effort. So we should, as the government, the CDC included, be encouraging this behavior. We should be mobilizing these people and making them feel proud of this effort because it's absolutely heroic and we need to encourage it. But we don't. We kind of give them a hard time when they wear a mask because, you know, that's who we are, healthcare workers, right? Only we get them. So we need to like break out of that thing because first of all, it's not a solution, but second of all, it doesn't mobilize the population into the like wartime footing. The president just said he's a war president. I don't really disagree with that statement. And you know what? It doesn't matter what your political party is. This is an enemy everybody can get behind. I don't think anybody's out there sympathizing with COVID-19, right? So we could all demonstrate some unity by putting our collective effort into this mask thing. And just think, the campaign posters would be absolutely awesome. Actually, these are propaganda posters. But yeah, I want you to make surgical masks, man. How about this one? I just took a bunch of World War II ones and I edited them. Yeah, I'm going to sell some surgical masks after I put these jars away. You give us face masks, we'll give them hell. I could do like a million of these. This is big fun for me. Wear a face mask. Loose breath costs lives, right? Kind of acclimate the entire population to wearing them, just like they do in Asia. You can help me sew surgical masks. Learn to sew on YouTube. Yeah, fabulous, man. Good news from home. More production. Surgical masks, N95s, vents, face shields. That's what we need. So this is the biggest threat, again, in my generation. I don't see why we wouldn't mobilize people who are doing nothing at home into feeling that they can contribute to this effort and do a reasonable job. This is where I think the government could be like laser focused here. And I don't think anybody would not feel good about this, and it would be useful. So my concluding thoughts for today: don't hate on lay people who wear masks. They're just absolutely part of the solution. We know it because it happened in Taiwan, in Hong Kong, in South Korea. We absolutely should not be hating on them. And we could be mobilizing our public to fight alongside with us, right? If they can't be out there manning IV pumps and transporting patients, they can absolutely be making some masks so we don't get sick. And that's happening. I already have a coworker who's positive. So we absolutely could be taking advantage of every man and woman who is willing to help out. So spread the word, man. Let's flatten this curve with the help of the population. See you next time.